Thank you, Daniel. Thank you, Frances. Sorry. Very happy to be there because this is my first time in Dublin. So very briefly, I want to illustrate some respiratory strategies to protect the cardiovascular system and especially the right ventricle in patients ventilated for acute respiratory distress syndrome. Just I want to remind you some key points before illustrating how to protect the right ventricle. The first one is that ARDS is not only a disease of the lung, of the alveoli, but also a disease of the pulmonary circulation. And you may read this very nice review from Laura Price. And you can see that in ARDS, you have very, very frequently an increased pulmonary vascular resistance, either because of the diseases, and you can do nothing. I mean, because of the inflammation, mediators, hypoxemia, you may have some obstruction of the pulmonary circulation at the capillaries level. But also, as you can see, you may act here on the extrinsic compression of pulmonary capillaries that you may induce if the respiratory settings are not adapted to the situation. The second point that I want to remind you is that using the PA catheter, and this is an ancillary study from the NIH, you can see the transpulmonary gradient. What is the transpulmonary gradient? This is the difference between the mean pulmonary artery pressure and the PaOP. And you can see that the transpulmonary gradient is really a reflect of the severity of the pulmonary circulation injury. And you can see in this very nice study that most of patients had increased transpulmonary gradient, and much more interesting, you can see that higher the transpulmonary gradient was, higher the mortality was. Finally, the third point that I want to remind you is that if you do a big mistake in terms of mechanical ventilation strategy, you may kill your patients. And it was very well illustrated in this study published in the New England Journal of Medicine using high-frequency oscillation ventilation with very aggressive settings, I mean very high mean airway pressure. And you can see the control group with protective mechanical ventilation and the HFO ventilation group. And you know that they demonstrated a significant difference in terms of mortality in the HFO group. And if you look at in the supplementary data of this nice paper, you can see here the percentage of patients who required vasopressors one day following the randomization between the control group and the HFO group. And you can see that near 80% of patients in the HFO group required some norepinephrine or catecholamine infusion. And that's interesting because using the echo, it's very easy to evaluate the impact of such a deleterious strategy on the right ventricle. And it was done by a French team working in Marseille, published in Critical Care Medicine in 2012. You have here, using the TE, you have the percentage of patients in white having a right ventricular dysfunction, and in green having right ventricular failure. This is a more serious state. And you can see here before the HFO, you can see a significant number of patients actually had some right ventricular systolic dysfunction. They were all ventilated for ARDS, obviously. And you can see by increasing the respiratory settings, the mean airway pressure, applying HFO ventilation, you may see a huge increase in the incidence of right ventricular failure. So definitively, if you apply this kind of ventilatory strategy, this is seriously deleterious for your patients. So how to do in practice? I want to show you some recent data that we did not yet publish, and that we did this study with Armand Meconceau-Dessap and Philippe Vigneault, two French intensivists. And you can see that we had a multicentric cohort of more than 700 patients ventilated for ARDS with a protective ventilation, and they all had an echocardiography in the first 2 days following the mechanical ventilation. And you can see here the main parameters which were associated with increased mortality. You have some very expected parameters as the age, the SEPS2 score, or shock, which is very well known as significantly associated with prognosis. I want just to comment the fact that shock is associated with mortality, whereas the P/F ratio was not associated with mortality. So just keep in mind that maybe that the approach to absolutely correct the P/F ratio, it's not very obvious or suitable in this situation. And you can see that severe ACP was also associated with a poor prognosis. So what is severe ACP? This is acute cardiopulmonale, but a severe acute cardiopulmonale. This is the case here. You can see this is TE. You can see the right ventricle. You can see the left ventricle. And this is severe because you can see that the right ventricular dilatation is severe. The right ventricle is bigger than the left ventricle. And on the transgastric view, you can see the paradoxical septal motion, just reflecting the right ventricular pressure overload. So the association of the severe right ventricular dilatation plus paradoxical septal motion define severe acute cardiopulmonale, which was associated with a bad prognosis in our large series of patients. And if you look at now the different parameters associated with the occurrence of acute cardiopulmonale, you can see that the first one is the pneumonia-related ARDS. The second one, and it's very interesting to see that, is the driving pressure. Higher the driving pressure, higher the risk for acute cardiopulmonale. This is the P/F ratio below 100 because of the hypoxic vasoconstriction, and this is the increased PSCO2 because the hypercapnic vasoconstriction. And so if you keep in mind these different parameters which are related to the occurrence of ACP, you have an idea how to protect the right ventricle and how to apply the suitable respiratory strategies to protect the right ventricle. So I have no time to go too much into the details, but I don't remember. Maybe Michael showed you this slide yesterday. You have different targets that you have to reach to protect the right ventricle. And the first one, obviously, is to limit the plateau pressure and the driving pressure. The second one is to limit the PSCO2. The third one is not to do a big mistake by applying a too high PEEP, which could be deleterious for the right ventricle. And finally, consider prone positioning, and I will show you some data, which is very valuable to improve lung mechanics, but also to improve right ventricular function. So just for the driving pressure, that's interesting because you know in this paper published in the New England Journal of Medicine that you may have some huge increase in mortality if the driving pressure is higher than 40 or 15 centimeters of water. So you have to keep this driving pressure lower, and this makes sense when I told you that the driving pressure is related to the occurrence of ACP. A few words regarding the PEEP. Look at this study that we did with armomecon-sodosap using echo. You have here the recruitment, the lung recruitment by applying a high PEEP. And you have here the effect of applying this high PEEP on the decrease in nervous stroke volume using echo. And you can see some inverted relation, very small number of patients, so it's just maybe a concept. It remains to be definitively proven, but you have two kinds of patients. In some patients, when you apply a high PEEP, you did not induce any significant lung recruitment, and so probably that you induce a significant overdistension, and you have, as a consequence, a big effect on right ventricular systolic function. This is the case of this patient. You can see that this patient was septic. He had ARDS. He was septic because you can see that he was tachycardic with a left ventricular hyperkinetic. The left ventricle was hyperkinetic. And you can see no right ventricular dilatation, no paradoxical septal motion. The PEEP was 7 centimeters of water. Look at what happens after 1 hour following the increased PEEP from 7 to 14. In this patient, you can see now a huge dilatation of the right ventricle and a paradoxical septal motion. So this patient had a small recruitment and a high overdetention, and so a very deleterious effect of the high PEEP on the right ventricular function. But you have another group of patients. Look at here. This patient, when you increase the PEEP, you can see a huge increase in lung recruitment, and so as a consequence without any significant effect on the right ventricular function. And this was nicely demonstrated in animals. This is a study published in the Blue Journal in 2003, and this is a model of lung atelectasis. And you can see here the right ventricular impairment score that they used in this study, using once again echo. And you can see at baseline before the atelectasis, and you can see here no right ventricular dilatation, no paradoxical septal motion. And you can see what happens after inducing some atelectasis, so decrease lung aeration, and you can see as a consequence some right ventricular dilatation, because probably that in this situation the lung stress significantly increased. And look at after the post-recruitment maneuver, so decreasing the atelectasis, you can see a quite normalization of the right ventricular function. So in some patients, because the lung is very poorly aerated, if you significantly recruit the lung, you may also improve the right ventricular function. And this is exactly what Michael showed you yesterday. This is and Sheldon McDare. This is the U-shaped relationship between the lung stress and the pulmonary vascular resistance described by Wittenberger. And maybe here, if you have too low PEEP, when you increase the PEEP, you decrease the pulmonary vascular resistance, and so you improve the right ventricular function, as I show you in the animal model. Maybe here you have too high PEEP, the lung is too much over-distended, and so you have some increased right ventricular pulmonary vascular resistance, and so it's very deleterious for the right ventricle. And in between, this is the optimal PEEP, but at that time we do not know how to titrate the PEEP to render the PEEP optimal. A few words very briefly regarding the recruitment maneuver and the right ventricular function. I like very much this study from Jean-Jacques Ruby's team, published in Anesthesiology. You can see different approach. A model of ARDS with a PEEP of 5. Look at how is the lung. With PEEP titration, so applying a high PEEP. Look at how is the lung. Not very in a good shape. And look at more interesting after PEEP titration and recruitment maneuver, you can see a very, very deleterious effect of the recruitment maneuver on the lungs. But also, we have data that this is also deleterious for the right ventricle. And it was demonstrated in pigs, in intensive care medicine in 2006. You have a model of ARDS in pigs, in hypovolemic pigs, normovolemic pigs, and hypervolemic pigs. And you have here the cardiac output on the aorta, or the cardiac output at the pulmonary level during the recruitment maneuver. And you can see a very, very big drop of the cardiac output when the recruitment maneuver was applied. And look at, they perform not really TE, because in pigs it's difficult to do TE. They just put the probe into the chest, and they were just behind the heart. And you can see here, just before the recruitment maneuver, no right ventricular dilatation, and during the recruitment maneuver, look at how is dilated the right ventricle, and look at the D shape of the left ventricle with the septal flattening. So very bad effect on the lung, and also as a consequence on the right ventricular function. Finally, a few slides very quickly regarding the prone positioning, which is not now a rescue therapy, but you have really to have in your strategy in the most severe patients. You know the ProSEVA study published in the New England with a very, very significant decrease in mortality in the prone positioning group. And what is especially interesting, this is this paper published a few months later in the Blue Journal in 2014. And you can see that in the ProSEVA study, the effect on mortality was not related to the effect of prone positioning on gas exchange. It means that maybe you had patients who survive, but without any effect regarding blood gas analysis, I mean regarding increased PONF ratio or decreased PaCO2. So then there is no link between the beneficial effect of prone position on mortality and the effect of prone position on gas exchange. And this is really an important thing to keep in mind. So there is another mechanism that only improving the gas exchange. And if you look at the results of the PROSEVA study regarding, for instance, the number of extrapulmonary organ dysfunction 3 days up to 28 days after the randomization, you can see that in the prone group, there are more days without any extra organ failure dysfunction. And especially, that's interesting to comment the fact that in the prone group, there was less cardiac arrest compared to the supine group. So really a cardiovascular effect of prone positioning rather than a blood gas effect. And if you look at the respiratory settings in the PROSEVA study, you can see that the PEEP was below 10, the plateau pressure was below 25, the driving pressure was below 15, and the PSCO2 was around 50 millimeters of mercury. So this is a very, very protective right ventricular approach. So maybe explaining in part the beneficial effect on survival. That's true because we demonstrated a few years ago that prone positioning may improve the right ventricular dysfunction. And look at this patient, for instance, ventilated for ARDS. You can see some paradoxical septal motion before the first session of prone position. This patient had acute cardiopulmonary, and you can see after 18 hours of prone positioning, you can see a complete normalization of right ventricular function. So just by decreasing the plateau pressure, the driving pressure, maybe decreasing a little bit the PSCO2, the prone position is able to improve the right ventricular systolic dysfunction by decreasing the right ventricular afterload. So in conclusion, there is no magic strategy. I think that we all agree about that. Strategy, and we all agree about that, has to be adapted patient per patient, especially for PEEP titration. And echocardiography may be a big, big help, and you have to use it to adapt the respiratory settings patient per patient. There is a clear, strong concordance between ventilatory strategies, which has been proven to improve prognosis, and their beneficial effect on the cardiovascular system, and especially the right ventricle. And I think that that's my feeling. A right ventricular protective approach has to be considered and maybe to be now really studied in a randomized control study. Thank you for your attention.